Good afternoon. It's my great pleasure to welcome all of the attenders on our webinar. I hope you will find the webinar interesting and helpful in your daily clinical practice. The subject of our webinar today is challenges in the management of non-metastatic thyroid macrocarcinoma. It is a condition which is a subject of interest of Endo-ERN. So we start with a short description how to define the disease. Next will be a lecture devoted to optimization of subthecal treatment in differentiated thyroid carcinoma. After short discussion, we have some words about borderline thyroid tumors. This is new histopathological entities, very challenging in diagnosis. The next step is to describe molecular markers and their potential role in the treatment decision making in these patients. Next lecture concerns the postoperative radioiodine treatment. Is it necessary for all intermediate risk patients? And at the end, some closing remarks to sum up our webinar today. So how the webinar will run. So after each presentation there will be a short discussion, 5 minutes discussion. Each attender has the opportunity to ask the questions. You can submit your question via question box. Moreover, the webinar will be recorded for review purposes and it will be available afterwards on our Endo-ERN website. Also, if some question, if the time for discussion will be too short to answer all questions, we will try to answer your question via email. So let's start. My name is Jolanta Krajewska. I am an endocrinologist. I work in Maria Skłodowska-Curie National Research Institute of Oncology in Gliwice, in a tertiary reference center for thyroid carcinoma. We are a member of Endo-ERN since the beginning. So thyroid cancer is also of interest of the European reference networks. To meet the criteria of a rare disease, thyroid cancer was divided into two groups. The first one is non-metastatic thyroid cancer, and the other one is advanced thyroid cancer. I'm sorry. The non-metastatic thyroid cancer group excludes thyroid microcarcinoma, which is currently a very common disease and is diagnosed in about nearly 50% of patients in Poland every year. Non-metastatic thyroid carcinoma is of interest of Endo-ERN network, whereas advanced thyroid cancer is a part of EURACAN network. Moreover, Endo-ERN brings together endocrinologists, while EURACAN network brings together endocrinologists and oncologists dealt with thyroid cancer. As you may see, both networks are in fact interested in all types of thyroid cancer. So differentiated thyroid cancer, medullary thyroid cancer, and poorly differentiated thyroid cancer are of interest for Endo-ERN. Similarly for EURACAN. And in addition, anaplastic thyroid cancer is the disease on which EURACAN focuses. So non-metastatic thyroid macrocarcinoma is not a homogeneous entity, clinical entity. You may see that the disease concern low stage of differentiated and medullary thyroid cancer, but also when if in these groups with red arrow non-lymph nodes metastases are diagnosed, also higher initial stages of thyroid cancer may belong to a group of non-metastatic thyroid carcinoma. This clinical entity also includes patients who differ in their level of postoperative risk of recurrence. So we have low, intermediate, and high-risk patients. The current criteria how to define the risk group were proposed by American Thyroid Association in 2016. You may see these criteria on this slide. And similar criteria you may find also in the most current ISMO guidelines. As you may see, the risk of recurrence is very low in the low risk groups. However, in high risk group, the risk of recurrence varies between 30 and even 100%. So, considering this data, the management of non-metastatic thyroid cancer could be a real challenge for clinicians. One of the most important questions is of whether we are able to predict non-metastatic thyroid carcinoma before the operation. Here you may see our own analysis involving more than 700 patients newly diagnosed with thyroid cancer between January and September 2020. In these groups, more than 300 patients had thyroid cancer bigger than 10 millimeters in diameters, and among them nearly 180 have thyroid tumor between 11 and 20 millimeters in diameters. So, and in this last group, 90 patients were finally diagnosed with low risk DTC, 55 patients with intermediate risk DTC, and finally 24 patients with high risk DTC. So, however, based on preoperative results of fine needle aspiration biopsy, the risk stratification of these patients would be very difficult, or even in some cases, in many patients, it will be not possible. Another question arises of whether there are some molecular markers that will be helpful to define the risk preoperatively. This is the subject of the lecture prepared by Dr. Rusinek you will have in a minute. There are some other very important questions regarding daily management of non-metastatic thyroid carcinoma. The questions related to the extent of surgery, lobectomy or total thyroidectomy, depending on tumor size, new histopathological entities. It is a new clinical problem and a real challenge to diagnose them and to follow up them. The question about molecular markers, which are helpful in such patients. Still ongoing question is the question regarding postoperative radioiodine treatment. Who should be treated? Particularly today will be discussed in the intermediate risk patients. Thyroxine suppressive therapy for whom? And other question could concern follow-up, how long, who is responsible, endocrinologist, reference center, and for sure there are many other questions not listed here. We try to answer some of them during this webinar. So I hope the other lectures will explain why the management of non-metastatic thyroid cancer is a real challenge for endocrinologists. Thank you for your attention, and we may start the.
Thank you, Jolanta, for the introduction. You will see the questions put in the check in the question box. Please ask Jolanta on different teams. I encourage you.
So currently we do not have any new question in the question box. However, we wait for a minute. I realize that this is the introduction and just
yes.
Maybe some more question will be after other talks.
Yes, may I have the question and ask Jolanta? Endo-ERN expects from us that we give data on the rare disease to the registry. And how do you qualify non-metastatic thyroid cancer?
In fact, it is very difficult because it is difficult to predict whether non-metastatic thyroid cancer at the beginning will be non-metastatic during the whole treatment of the disease. However, we try to base our assessment on histopathological examination. We based the assessment on the tumor diameter, on the presence, on the information on lymph node metastasis, and any initial information regarding distant metastasis. So such list is based on clinical and histopathological data.
Thank you. Do you see any other questions?
I can no, there are no other questions. So
okay. Then I think that it is time to introduce the next lecture. Thank you, Jolanta, very much for your presentation. And I had the pleasure to introduce Agnieszka Czarniecka, who is a very experienced thyroid surgeon, but also board certified endocrinologist. And she will tell us about difficulties in optimization of surgical treatment in differentiated thyroid carcinoma. Agnieszka, the microphone is yours.
Good afternoon, everybody. Thank you very much for the invitation and giving me the possibility to discuss about these difficulties in optimization of surgical treatment in differentiated thyroid cancer. As we well know, today we can observe a so-called thyroid cancer epidemic, but the increase in thyroid cancer incidence has been especially observed in low-risk cancer groups. Surgery is still the primary and main therapeutic option in differentiated thyroid cancer. However, due to the lack of randomized controlled clinical trials, the discussion about optimal extent of surgery is still open. And before we starting with any kind of therapy, we should ask following questions. How to choose the optimal therapeutic strategy and predict poor prognosis in differentiated thyroid carcinoma, to avoid over and under treatment. And the arguments pro and cons total thyroidectomy are as follows. The supporters of total thyroidectomy stressed that this extent of surgery result in the reduction of local risk recurrence, the increase in effectiveness of radioiodine therapy, giving the possibility of using thyroglobulin as a sensitive marker of the disease, and finally result in the elimination of conversion risk to poorly differentiated cancer. But the opponents of such strategy stressed that in low-risk papillary thyroid carcinoma and in minimally invasive follicular thyroid carcinoma, we have generally favorable prognosis, and lobectomy in this group of patients result in the reduction of risk of surgical complications. And the management in papillary thyroid carcinoma differs depending on the country. And what is very interesting, that in the same country, in the United States, before, before 2009, two different kinds of recommendations existed. On the one hand, American Society of Surgical Oncology and National Comprehensive Cancer Network recommended that extent of surgery should depend on the evaluation of risk factors. At that same time, American Thyroid Association guidelines, which were similar to European ones, recommended total or near total thyroidectomy with central neck dissection in almost all cases of papillary thyroid cancer. And that time we could find as many publications for as against less extensive surgery. Even in the same journal, we was able to observe the discussion between supporters and opponents of the total thyroidectomy. That time we performed our retrospective analysis in the group of more than 1,100 patients, and we observed that the extent of surgery is an independent prognostic factor, significant both for overall and disease-free survival. But what is important, that the meaning of the extent of surgery was observed only in patients in a clinical stage above T1A. In microcarcinoma group, we didn't observe any differences in prognosis independently of the extent of surgery. But in T1B patients group, the disease-free survival was worse when the tumor size was above 1 centimeter. And in 2009, American Thyroid Association decided that lobectomy should be primary initial surgical treatment in low-risk papillary thyroid carcinoma patients in clinical stage T1 and 0M0. And that time in Poland, total thyroidectomy was still recommended almost in all cases of differentiated thyroid carcinoma, but the committee decided that for lobectomy in papillary thyroid microcarcinoma should be performed clinical trials. And we performed such a trial, and between 2011-2015, we performed prospective non-randomized trial to evaluate whether less extensive surgery is safe and sufficient in patients in clinical stage T1 and 0M0. And in patients with microcarcinoma, with unifocal thyroid cancer without any significance of lymph nodes involvement, we proposed and performed only lobectomy. The reduction of surgical extent in T1 group was performing only ipsilateral central nerve dissection, and total thyroidectomy was still performed in this group of patients. And the results of this study was published this year, and with mean follow-up over than 5 years. And what is important, that from the group of 160 patients who were referred to lobectomy as initial treatment, only 12 patients, 7% of them, refused to participate in clinical trials, and they underwent total thyroidectomy with bilateral central nerve dissection. And in the group of almost 140 patients who underwent lobectomy as initial treatments, based on TNM 7th edition, the postoperative advancement of the disease was the same in 77, was confirmed in 77% of patients, and 24 of patients had to be reoperated. And what is interesting, that 8 patients refused to be reoperated on, and in this group of patients we didn't observe any relapse. And when we look at the risk of relapse in this prospective group, please notice that in microcarcinoma group we found only 1 relapse, and it was in patient who was reoperated on due to multifocality. So finally, total thyroidectomy was performed, but the relapse was observed during further follow-up in central lymph node compartments. And in T1B, we observed two local relapses in a lateral lymph nodes compartment. And when we compared the results of the therapy in prospective group with retrospective one, and patients from retrospective group underwent total thyroidectomy with bilateral central nerve dissection, we didn't observe any differences with the risk of local relapse. And we didn't observe also differences between disease-free survival independently of the extent of surgery. And what was expected, the lobectomy absolutely reduced the postoperative risk of early hypoparathyroidism. And the results of this trial confirmed that the less extensive surgery in properly selected low advanced papillary thyroid carcinoma is both safe and sufficient. And in this group of patients, currently we may perform less extensive surgery, meaning lobectomy or hemithyroidectomy, but these patients may be referred also to active surveillance and to image guide minimally invasive ablation techniques. And in 2015, American Thyroid Association went further, and they proposed that lobectomy may be safe and sufficient also in T2 and 0M0 group. And at present in America, all societies agreed that the extent of surgery should depend on the evaluation of risk factors. But in Europe, the discussion on the modification of recommendations is still going on. But we should still remember that when American Thyroid Association decided to change their recommendations, they based on analysis of overall survival, they analyzed the risk of the death, not the risk of local recurrence, and they based on the data from large single center groups and national center database or SEER database. So these studies were retrospective ones. And this year, American researchers published the results of a survey. They performed this survey between high volume and low volume surgeons, and surgeons decided and agreed that lobectomy is still safe and sufficient only in microcarcinoma group. And in T2 and 0 group, only about 10% of surgeons decided to perform lobectomy as the initial treatment. And using the same National Cancer Database data, these researchers observed that total thyroidectomy was associated with improved survival in patients with T2 and 0 group, and they concluded that lobectomy is not sufficient for such an advancement. And the European Association of Nuclear Medicine stressed the necessity for European modification of American Thyroid Association Guidelines 2015. And European panelists suggest the modification to approximately 1/3 of ETA 2015 recommendations. And one of them is a recommendation for a lobectomy using in T2 and 0 group. And last year, the American Association of Endocrine Surgeons published their revision of their guidelines, and they analyzed the clinical factors to favor initial total thyroidectomy and versus lobectomy, and they were consistent that lobectomy is favorable, is still safe and sufficient only in microcarcinoma, and this extent of surgery is controversial in papillary thyroid carcinoma above 1 centimeter in diameter. And the British research of almost 300 patients is very interesting because they analyze the patients who met ETA preoperative criteria for lobectomy, and they found that almost 25% of patients would require completion of thyroidectomy due to discordance between preoperative and postoperative advancement of the disease. They found 30% of angio invasion and 35% of local invasion. And they also stress that in high volume surgeons, the total thyroidectomy is absolutely safe surgical procedure. And at present in Poland, we are going to prepare another revision of our recommendations, and we decided that lobectomy may be considered in low-risk papillary thyroid carcinoma patients stage T1 and 0. And in this group of patients, completion of surgery may be abandoned, but we still will be recommended total thyroidectomy in patients T2 and 0 stage. And currently, when we decided about optimal extent of surgery, we should take under consideration the results of molecular tests, if they are possible, and the change of pathological classification. We should search for additional tools to reduce the risk of postoperative complication, and we should also consider to use other technique like image-guided minimally invasive therapy. And current therapeutic strategy should be performed by multidisciplinary team, and a lot of specialists should take under consideration all clinical, histopathological, molecular factors and patient decision, also to stratify the benefit-risk ratio for selection of the best therapeutic option. What is not so easy for every patient. So thank you very much for your attention.
Thank you, Agnieszka, for the very interesting lecture. And Jolanta will check whether there are already questions.
Yes, I have. We have one question asked by Chris Popper. I read the question. I would be careful in the interpretation conclusions of your study results because you included a small number of patients in the groups lobectomy versus total thyroidectomy. This is the question, Agnieszka. Can you answer?
Yes, of course. The small group of this patient is, of course, the main limitation of the study, but it was the first study who was real prospective one. So it is we analyze the difficulties to implement new type of therapy, because before 2010 in Poland, total thyroidectomy was the standard therapy for all papillary thyroid carcinoma patients diagnosed preoperatively. And it was the preliminary study, and another reason that this is a small amount of patients who decided to be operated in this new so-called new procedure is that in Poland, in European countries, we have more multinodular culture than in the United States. So it's not so easy to find patients with really single lesion in thyroid. So I absolutely agree that the small amount of patients including in the study is the one of the most limitation of it.
There is another question from the audience. What about DTC management in children?
It's it's a very good question. Due to the difference in clinical outcome in children and the increase in the risk of lymph nodes metastasis both in central and lateral compartment, we still recommended to perform total thyroidectomy in all children in whom papillary thyroid carcinoma is diagnosed preoperatively, independently of the size of the lesion.
And currently I don't see any other question. Do you have any other question you want to ask? So if not, Agnieszka, can I ask you one question?
Really?
what is your opinion about the tumors localized in the isthmus? The small tumors, for example, PT1B in the isthmus, do they need total thyroidectomy, in your opinion?
PT1B, it's very difficult. It depends. Isthmus localization is difficult due to the risk on easier infiltrate the surrounding tissue. And of course, now we have the 8 TNM classification when the minimal invasion of the fatty tissue is still microcarcinoma, but as Daria probably will mention further, this is the so-called intermediate cancer, and maybe adjuvant iodine therapy necessary in these patients. So they may be referred to completion of surgery. So if I have any suspicion of infiltration surrounding tissue, I must discuss with patients so-called B-steps thyroidectomy. We may start with lobectomy plus hysterectomy, but the patient must be informed about the possibility of the next surgical intervention.
Thank you very much for this explanation. And I have one more question from the audience. What is your opinion on minimally invasive techniques like RFA in PTMC, in papillary microcarcinoma, when these techniques may be better than lobectomy?
These techniques may be better in patients who are at surgical risk, who are fragile, who deadline to undergo surgery. So, of course, it's not routine treatment, routine way of therapy, but it may be useful in selected group of patients.
Thank you so much. And the last one, there is a question: what is the management of neoplasia? How would you define neoplasia? I don't know what neoplasia. I don't know what exactly what does exactly mean. Maybe it concerns follicular neoplasm.
Follicular neoplasm?
I don't know.
Single is indication for lobectomy. If this lesion is in multinodular goiter, the total thyroidectomy will be also considered. But I don't know what does this neoplasia means.
Thank you so much. Thank you for your excellent lectures. Now we have time to move to the next presentation.
Thank you very much.
Thank you very much. Pani profesor, nie słychać. I'm sorry, Barbara, I can't hear you.
Good afternoon, ladies and gentlemen. My name is Eva Chmielik. I will present the lecture, Borderline Thyroid Tumors, Challenges in Histopathological Diagnosis. In the current WHO thyroid tumors classification, we have 4 entities defined as tumors of uncertain malignant potential: follicular tumor of uncertain malignant potential, well-differentiated tumor of uncertain malignant potential, non-invasive follicular tumor, follicular thyroid neoplasm with papillary-like features, and hyalinizing trabecular tumor. In my presentation, I will concentrate on 3 entities because they are the most challenging in thyroid pathology now. According to WHO definition, thyroid tumors of uncertain malignant potential are encapsulated or well-circumscribed follicular patterned thyroid tumors with questionable capsular or vascular invasion, irrespective of the presence or absence with papillary carcinoma type nuclear features. So in follicular thyroid tumor of uncertain malignant potential, we have well-differentiated follicular cells without nuclear features of papillary thyroid carcinoma. In this tumor, we can recognize questionable capsular or vascular invasion, and this tumor is indeterminate between follicular adenoma and follicular carcinoma. Also called atypical adenoma, it is important to know this synonym because sometimes you can meet atypical adenoma in literature. The second entity, well-differentiated tumor of uncertain malignant potential, is also collected from follicular cells, but the cells present a larger nuclei or a few nuclear grooves, usually no pseudo-inclusions, and capsular or vascular invasion is questionable as well. When we go to any of the FTP, NIPT is a first entity which I will describe in my presentation. I start to tell you that it is a challenge entity. It is a challenge entity on macroscopic and microscopic level. Careful macroscopic examination is very important from the start of the diagnostic process. Even one section from the tumor can contain excluding features, and this one section can decide about the patient's outcome. So careful examination of entire tumor and entire, especially capsule of the tumor is very, very important. Suspected NIPT tumor is even several dozen blocks, so it's not a simple diagnostic process. It is also complicated on a microscopic view because differential diagnosis of NIPT combines few entities, as you can see on this diagram. In this group of differential diagnosis, we can include papillary thyroid cancer, follicular thyroid cancer, WDT, well-differentiated tumor of uncertain malignant potential, poor-differentiated thyroid cancer, and follicular adenoma. As you see on this diagram, diagnostic criteria we can divide into few groups. The first one is margin. Non-invasive follicular thyroid neoplasm with papillary features should be encapsulated or clearly demarcated tumor from adjacent thyroid parenchyma without capsular invasion or without angio invasion, without infiltrative pattern. Should be follicular pattern tumor. Usually it is microfollicular, without papilla, without psammoma bodies, and with cytology which is similar to thyroid, to papillary thyroid carcinoma cytology, but some features are different. The tumors can be larger than normal follicular cells. Nuclear membrane are irregular, and chromatin clearing, but definitely no necrosis and no high mitotic activity in this tumor can be encountered. Special scoring nuclear system for evaluating nuclear features were established and published in 2016, and the nuclear features are evaluated according to size and shape, according membrane irregularities, according chromatin characteristic. So NIPT diagnosis is not quick and easy. It is a multi-stage diagnostic process. It is a time-consuming process, microscopic and microscopic approach supported by immunohistochemical and molecular tests sometimes is required, because sometimes we need to exclude for example, a BRAF mutation using immunohistochemistry or molecular test to be safe with diagnosis of NIPT. And definitely is this diagnosis need broad experience in thyroid tumor pathology. Tumors of uncertain malignant potential should be confirmed by a second pathologist from the reference center. And according to our experience, a risk of recurrence or metastasis is very low when the tumor is confirmed in the reference center, but patients should be observed. And there is a question if patients should be observed at the reference center by endocrinologist, or should be followed by GP in contact with the reference center. We go in further to other entities, undifferentiated malignant potential tumor, follicular tumor, and well-differentiated tumor. As you see also in this diagram, follicular tumor of uncertain malignant potential need to be differentiated with follicular adenoma or hyperplastic nodules, and also with follicular carcinoma, minimally invasive, follicular carcinoma, widely invasive, and purely differentiated thyroid carcinoma. So invasion, antigen invasion, and capsular invasion is crucial. And also crucial in a well-differentiated tumor are nuclei. Nuclei we can analyze going through a few publications which are started from 2009, when the French pathologist group directed by Paul Hoffman described 30 tumors of uncertain malignant potential, and they show us on such picture that nuclei PTC-like can be diffuse focally, or can be heterogeneous follicular pattern. As you see in the second publication which published in 2010 by Kakudo, so Japanese pathologist group. They detailed more carefully tumors nuclei, and they compared nuclei size to normal follicular cells, and they show us that usually tumor nuclei are 2 or 3 times bigger than normal cells. Nuclear clearing were present in all tumors, and nuclear growths can be accounted in 1 or 3% of tumors. When we go to a publication, the second publication about uncertain malignant potential tumors, published by Turkish group, and we can see that nuclei size, analyzed nuclei size were normal, or 2 or 3 times bigger than normal cells. Nuclear clearing was present in almost all tumors, and nuclear growths were present in 1 or even 5% of tumors. Next publication from equivocal nuclear features and well-differentiated tumor of uncertain malignant potential, Japanese publication, also gives us some indication how to approach to such tumors. The authors analyzed immunohistochemistry. Can immunohistochemistry be helpful in our practical routine? I think that is not very helpful. As you see on this table, we can analyze three antibodies: HBM1, CK19, and Galectin-3. And you can see that some tumors are diffusely positive in 3 stains, but there are many tumors that are completely negative. So we have we couldn't find this examination as helpful. Also, French group show us 2 antibodies that are sometimes could be diffuse, at another time could be very focal. So it's not helpful as well in both entities: well-differentiated tumor of uncertain malignant potential and follicular tumor of uncertain malignant potential. Capsule provides us information about microenvironment of tumor, and it is also very important feature in tumors of uncertain malignant potential. When we analyzed the capsule in follicular tumors and comparing with well-differentiated tumors, we can find that thick capsule is more often in follicular tumors of uncertain malignant potential, while thin capsule is encountered in well-differentiated tumor of uncertain malignant potential more often. Incomplete capsule is also encountered in the same tumor type. So capsule with questionable invasion is more often found in follicular tumors of uncertain malignant potential. There are some examples from literature. I present pictures from chapter wrote by Giovanni Tallini in Encyclopedia of Pathology. He presents tumors of uncertain malignant potential with a thin capsule and uncertain equivocal capsular invasion, irregular protrusion of neoplastic cells at the tumor interface. And the second example, you can see thick capsule also with hook-like structure with questionable capsular invasion. Capsular examination is very important in encapsulated tumors like uncertain malignant potential tumors, and even Japanese surgeon recommend a special type of cutting the capsule. They recommend sagittal cuts and perpendicular cuts at the peripheral part of the tumor. Other manner for the cutting tumor and capsule are provided by a Korean pathologist group. They introduced modified transverse vertical growth examination. To sum up, Japanese pathologists show us in this publication that additional tissue sampling trials did not change the practice. Histological assessment of capsular invasion in follicular thyroid neoplasm has inter-observer variability, and this problem was analyzed by pathologists from the East, and they show us that benign, borderline, and malignant tumors are not well repetitive in interpretation between different pathologies, as you see. Borderline tumors can be examined and can be recognized by in 5% or in 55% in the same group of tumors. So it is a big problem. And another problem is angioinvasion. There is a different criteria for angioinvasion in WHO classification and in College of American Pathologists. Why in WHO we have the criterion for angioinvasion, we have tumor cells inside the vascular space, endothelial covering, or with clots. Why in College of American Pathologists, endothelial cover does not meet the criterion. So there is different groups of tumors when we put this criterion and this criterion according to different societies. Can in such differential problems, can we support other methods? I think that we should follow according this Swedish publication, which advise us to put TERP promoter mutation examination for atypical adenomas or tumors with uncertain malignant potential, and they found that promoter mutation of third promoter is important in group of such tumors, because in 8 tumors with such mutation, 3 tumors developed distant metastasis and recurrence. So diagnostic criteria for borderline thyroid tumors are subjective, sometimes not very repetitive in interpretation, and they require correlation with molecular tests to select a group of patients at risk of metastasis. I think my time is over, but I have few slides extra if we have a time instead
If
of
you can continue.
of questions.
Eva, you can continue.
Yes.
Continue.
Okay, so I would like analyze capsular cutting of slides, and this is a table prepared by Dr. Magdalena Suchorzeb-Kasimek from our collection consult cases collection. And as you see, number of slides are not good enough for diagnostic process. So number of slides are very important in safe diagnosis, and it's not good enough. And now I go to criteria about capsular invasion. We know very well this figure from Fletcher book, Diagnostic Histopathology of Tumors, and we put this part different situation, this part of this figure in real slides. For example, such invasion of tumor is equivocal invasion. Another example of equivocal invasion is figure thick capsule, thick fibrous capsule, and this is a well-circumscribed tumor with calcified capsule, and we have invasion as well, but it's not full invasion by tumor, only by capsule, only partial invasion. So we have equivocal capsular invasion. It is not fulfill criteria for invasion of capsule, so it is again equivocal capsular invasion. And another example of unequivocal invasion in hook-like manner. And this very special example of capsular invasion or pseudo invasion, we can use special stain. It is a histochemic stain for Masson's trichome stain, and we can find some tumor cells outside the capsule. So it is invasion. So it is minimally invasive follicular carcinoma. And also angioinvasion, you can find such covering in the surface of tumor group. So endothelium is present, but clot is not present, and this vascular space is inside of fibrous capsule. According to WHO classification, and again the second example, that we have vascular space with tumor cells, but without covering of endothelium and without clots, and it is an example of unequivocal invasion. So that's all from me. Thank you for your attention.
Thank you, Eva, for the very interesting and comprehensive lecture. Are there any questions, Jolanta?
I haven't seen any question to Eva. However, if you have any question, please write them, and we answer. Eva answer all of them by email. I think because we extended the lecture by some minutes, so we have to go forward to the next lecture.
Okay, and this is my pleasure. Thank you, Eva, very much. This is my pleasure to introduce Dagmara Rysinek, who was not able to connect with us. However, fortunately, she prepared a video which will be shown now. Please, Sandra, show the video of Dagmara Rysinek.
Good afternoon. My name is Dagmara Rysinek, and I work in the Department of Genetic and Molecular Diagnostics of Cancer in the National Institute of Oncology. I'm sorry that I was not able to give this presentation live, but because of the previous commitments, it was not possible. But I'm glad that still I have the opportunity to present you the current state of knowledge concerning molecular markers in thyroid carcinoma and their practical application in making the therapeutic decisions. According to the global cancer statistics, thyroid cancers took 11th place in terms of prevalence in 2020. And as you all well know, since the 80s we can observe an increasing incidence of thyroid carcinoma cases, and it is mainly due to the progressively available ultrasonography and other imaging diagnostics, and it led to a massive detection of and diagnosis of a large number of small subclinical and indolent thyroid tumors, and to overdiagnosis, which is overwhelming when you see the numbers here, both among women and among men. However, a growing understanding of the substantial impact of overdiagnosis and understanding of the indolent nature of small thyroid carcinomas led to modifications of some of the national and international guidelines in terms of active surveillance of microcarcinomas. And this new approach led to a decline in thyroid cancer incidence rates in the Republic of Korea since 2010 and in the United States since 2015. Of course, there are also studies indicating that the increase in the incidence of thyroid cancer is real and not only and cannot be attributed only to the easily accessible ultrasonography and other diagnostic techniques, because we observe not only the rise in the incidence of small thyroid tumors, but also larger thyroid tumors were also observed. Nevertheless, there is a strong need to improve the diagnostics and treatment of thyroid carcinomas with the help of molecular biology and with the use of molecular solutions. And it seems to be crucial to identify molecular markers that can distinguish benign and malignant thyroid tumors, and that could predict aggressive biology of cancer, prognosis, recurrence, the efficacy of the treatment, and molecular markers that could be used as therapeutic targets. Since the discovery of oncogenic role of the BRAF V600E mutation in 2003, a number of novel molecular markers were identified in thyroid carcinomas. Although the total mutational burden of thyroid carcinomas is lower comparing to most of the other cancer entities, we know that the alterations, genetic and molecular alterations, are very important in thyroid cancers, and this was emphasized by the Cancer Genome Atlas project. In this study from 2013, papillary thyroid carcinomas were analyzed, and this study enabled the reduction of PTC fraction with unknown oncogenic drivers from 25% to 3.5%. This project also enabled identification of novel driver genes, and what is the most important thing, it introduced a classification of PTCs to two molecular subtypes, BRAF-like and RAS-like, which are similar in their gene signatures to BRAF V600E-driven and RAS-driven tumors. When it comes to mutations identified in this TCGA study, these alterations show distinct patterns affecting mostly two major signaling pathways, and these are the MAP activating protein kinase pathway, MAPK, and phosphatidylinositol 3 kinase AKT pathway. Alterations in these two signaling pathways lead to their constitutive activation, translocation of transcription factors to the nucleus, and activation of uncontrolled activation of genes involved in tumorigenesis. When it comes to MAP pathway, it is crucial for growth and proliferation of the cell, and it is altered in about 70% of all papillary thyroid carcinoma cases. And most of these alterations concern BRAF V600E mutation and RET translocations. It is impossible also not to mention about the third promoter mutations, which were identified in 2013, and these are two major hotspot mutations which generate de novo binding elements for ETS transcription factors, which lead to increased telomerase expression and immortalization of neoplastic cells. BRAF V600E mutation is most common in sporadic PTCs, comparing to pediatric and radiation-induced, and the rate of malignancy in BRAF positive nodules is about 100%. However, this genetic alteration is infrequent in indeterminate nodules, which are rather follicular patterned neoplasms, and this frequency is below 10%. When it comes to red PTC rearrangements, these are more common in radiation-induced PTCs, and detection of red PTC identified malignancy in about 60% of indeterminate nodules. However, you must remember that the presence of these alterations in benign nodules still remains debated. The second major signaling pathway in thyroid carcinomas, the PA3K AKT pathway, is crucial for regulation of apoptosis, proliferation, cell cycle progression, angiogenesis, and many other processes. And the most altered genes in this pathway are RAS genes. RAS mutations are believed to be a premalignant molecular event, and additional mutations are needed to set off carcinogenesis. And RAS mutations are most common in follicular thyroid carcinomas. They are present in about 40 to 50% of cases. However, these are not specific alterations for malignancy, because they are also present in follicular adenomas and in non-invasive follicular neoplasms with papillary-like nuclear features, NIFT. However, RAS mutations presence implies a neoplasm for which surgical management allows for further diagnosis and treatment selection. I would also like to say something about PA3K, 3CA gene, because the presence of mutations in this gene is associated with the probability of cancer in indeterminate nodules, cytology indeterminate nodules, more than 90%. According to the World Health Organization, there are many molecular markers that can be associated with different thyroid carcinomas, different thyroid tumors. However, please remember that some of them are also present in benign thyroid nodules. And this is important when we think about the use of molecular markers in thyroid cancer diagnostics. So moving on to the clinical utility of these markers, as you all well know, 20 to 30% of fine needle aspiration biopsy cases are indeterminate in cytological evaluation. And these are the B3 and B4 Bethesda classes. And these samples can be considered for molecular testing, of course, if these molecular tests are available. What I would like you to pay attention is when it comes to risk of malignancy, this parameter has changed after reclassification of NIFT in 2017. This thyroid entity, non-invasive follicular neoplasm with papillary-like nuclear features, this reclassification changed not only the nomenclature of some thyroid tumors, but also we can say that this gave acceptance for the existence of borderline and precursor lesions in the thyroid. And we can treat the B3 and B4 Bethesda categories as categories that can accommodate these borderline and precursor lesions. And these are not only NIFTs, but also follicular thyroid tumors of uncertain malignant potential. When it comes to NIFTs, the majority of them is located in the indeterminate categories with the prevalence of 31% in the B3, but as the class 26.6% in B4 and 24.3% in B5 Bethesda class. Unfortunately, the definitive diagnosis of NIPT is not possible on FNAC samples, and there are no specific genetic alterations that can be linked with a definitive diagnosis of these thyroid tumors. When it comes to molecular alterations that are present in these tumors, these are mainly RAS mutations in up to 60% of cases, but also PAX8 PPR gamma rearrangements and BRAF K601E mutation. Follicular thyroid tumors of uncertain malignant potential also similar to NIPTs demand careful histological examination of the capsule. However, there are studies that suggest that third promoter mutation analysis in these tumors could be very supportive in the diagnostic management, because third promoter mutational screening is a highly specific method in terms to detect tumors with true malignant potential. There are several commercial molecular tests that are present on the American and European market. Some of them are the rule-in tests that are intended to to detect malignancy, and some of them just like rule-out tests exclude the malignancy. And these are dedicated to the diagnostics of indeterminate thyroid nodules. The most known tests are Thyrosec and Affirma test. Thyrosec is a rule-in test which enables evaluation of more than 12,000 mutation hotspots and more than 100 gene fusions, and it prevents the surgical procedure in up to 61% of the patients. It is characterized by a high sensitivity and specificity, and high negative predictive value and positive predictive value. The Affirma test was the first developed in 2011. Since then, many things has changed. It was improved, and now it enables evaluation of about 500 mRNA panel, gene expression of more than 1,000 genes, copy number alterations, BRAF V600 mutation, or red PTC1 and 3 rearrangements. However, it cannot detect third promoter mutations. Thyrosec can, but Affirma cannot. And this GSC Affirma test reduced the number of suspicious nodules from about 60% reported by its previous version, GEC, to about 40% of cases. These tests are very expensive, unfortunately, and some of them can be performed only in centralized labs. That's why we decided to develop our Polish molecular classifier, and we developed it within a milestone project concerning molecular diagnostics and imaging in individualized therapy for breast, thyroid, and prostate cancer. Our molecular classifier is based on gene expression profile, and it supports cytological diagnostics of thyroid nodules. Unfortunately, I cannot give you more details about this molecular classifier because we are during the patent procedure. When it comes to molecular markers in thyroid carcinoma, of course, we need markers that will help us to distinguish benign and malignant tumors, but we also need markers that can predict, that would help us to predict the aggressiveness of the cancer. And the most promising markers are BRAF V600 mutation and third promoter mutations. However, only when coexisting together, because these mutations alone presented modest adverse effects, while this genetic duet had a robust effect on the poor clinical pathological outcomes of PTC, including extraterritorial invasion, lymph node metastasis, distant metastasis, and recurrence. Similar, the coexistence of RAS and third promoter mutations seems to have similar effects, and we can say that this is a complementary mechanism to that represented by the coexistence of BRAF third duo in driving the aggressiveness of thyroid cancer. Among other mutations that are associated with more aggressive thyroid tumors, these are mutations in TP53, EIF1AX gene, and beta-catenin. But these are more common in poorly differentiated and anaplastic thyroid carcinomas and are very rarely present in differentiated thyroid carcinomas. However, many studies indicate that it seems reasonable to recommend that the existence of mentioned markers of aggressiveness in DTC should favor more aggressive treatment. Arguments pro is that these only 7.7% of PTCs harbor a genetic duo of BRAF and third promoter mutations, so less than 10% of PTCs would be patients with PTC would be treated relatively aggressively based on the presence of these mutations. Also, papillary thyroid microcarcinoma cases rarely harbor high-risk mutations, so only a small fraction of patients with PTMC would be treated aggressively. However, PTCs with larger tumors, particularly those with diameter more than 2 centimeters, are associated with a higher risk of recurrence, and here prophylactic central neck dissection would be reasonable. When it comes to follicular thyroid carcinomas, patients that harbor high-risk mutations also favor aggressive treatment. So the existence of these genetic alterations, especially BRAF third promoter mutated duo, may be responsible for increased risk of failure of the current treatment. So the complete eradication of the disease in the initial treatment and subsequent active surveillance for the disease recurrence are needed. Thank you for your attention. If you have any questions, please do not hesitate to contact me.
Do not hesitate
to
contact me.
Goodbye.
Here's my.
Thank you, Dagmara. I think that we may ask you to provide questions in the question box, and Dagmara will answer them by email. Jolanta, do you see any questions?
Yes, I have one question to Dagmara. The question is, do you recommend molecular genetic testing for both PTC and MTC? So for sure, Dagmara will answer this question by email. But of course, if you have another question, please write, and we will also answer them later.
Okay, and I think that there is time to introduce Daria Handkiewicz-Junak, who will discuss the important question: is post-operative radioiodine treatment necessary for all intermediate risk patients? Daria, please.
Thank you very much, and good afternoon, and thank you for joining our webinar. And to start with the radioiodine treatment in the intermediate risk differentiated thyroid cancer patients, I would like just to start with this pivotal work that was published some time ago in 1994 by Mazaferi and Young, that shows that radioiodine really works in differentiated thyroid cancer, because if we applied radioiodine after the operation, the recurrence rate is reduced from about 40% in this set of patients to about 16%, and also the mortality rates dropped from 9 to 3%. And it was true also if we take into consideration then in the patients that were treated with radioiodine, there were more patients with lymph node metastasis, more patients with stage 3 disease, and more men than women. But we should also look at the time when the patient was treated. It was between 1950 and 1993. So our tools to diagnose the patient, our knowledge of the prognostic factors in differentiated thyroid cancer were completely different from what we know now. In 1994, in this work presented and published by Mazaferi and Young, risk factors were mostly based on tumor or lymph nodes histopathology, and after the operation on physical examination and whole body radioiodine scan. And nowadays, our standard of care diagnostic tools were not available this 30 years ago, and they are completely different. We have neck ultrasound and biochemistry to assess patient after the operations to know whether the operation was complete and whether there are any suspicion that there is a persistent disease. We have a much better knowledge of pathological prognostic factors. We have some molecular prognostic factors, and we have computer tomography and positron emission tomography to know whether the patient have distant metastasis or not. And this move in and development and the diagnostic tools was not only in differentiated thyroid cancer, it spanned in all oncology fields. And I would like just to show how it influenced breast cancer. At the beginning, it was a very radical approach with breast removal, with the removal of pectoralis muscle and axillary dissection. Then when we have a better knowledge of the prognosis in the patient, there was mastectomy with breast removal and axillary dissection. And nowadays, with this available tools for diagnosis, we can do in the appropriately selected tumors, we can do breast conserving surgery. And instead of axillary dissection, we do sentinel lymph node biopsy, and axillary dissection is only done if they are metastases. And it was also apparent in the adjuvant therapy. At the beginning, it was mostly based on TNM stage. Then nowadays, it's mostly done on this calculator to predict the risk of disease recurrence or death from the disease, and what then how it can be influenced by the adjuvant treatment. And in the future, and in some cases nowadays, we can just make the adjuvant therapy based on the molecular predictors. And the same was done in the differentiated thyroid cancer. As Jolanta already said, in 1916, American Thyroid Association just released these new guidelines where they divided differentiated thyroid cancer patient into three groups of risk after the operation. These groups are based mostly on the pathological risk factors, and we have low risk group that the risk of the failure is about or less than 5%, I should say. Then we have intermediate risk group that the failure is about 5 to 20%, and then we have the high risk group when patients are either with persistent disease after the operation on the risk of failure is more than 20%. And we have a very good quality data with respect to a low risk of the recurrence in the low risk DTC patient group. And just to mention the estimable-1 study from France, when in the patient with PT1, PT2, and 0 and 1 disease, we have a structural recurrence of less than 1% and biochemical incomplete response in 1% of patient, and more or less the same it was in the Hilo study from the British Hilo study, that we can see that after 5 years we have less than 5% of the disease failure. But of course that when the time span is increasing, we have some more recurrences, but still the number of the recurrences is rather low. But the best study, I think the best study with respect to the radioiodine treatment in the low risk group of DTC is ESTIMAP-2 study. It is a prospective randomized study that was lately published, the first result in the ECA Congress. And in the study, the intervention was either radioiodine treatment or follow-up. It were PT1A or PT1B tumors without lymph node metastasis or without clinical known lymph node metastasis. And the primary objective of the study was 3 years after randomization, the non-inferiority of the proportion of patients that had tumor-related events in the follow-up group as compared to the ablation group. And these tumor-related events were defined by the occurrence of subsequent treatment, radioiodine or surgery, on the abnormal uptake on the post-therapeutic whole body scan or elevated thyroglobulin or abnormal neck ultrasounds. And when we come to the results, we can see that after 3 years, there were no differences between patients that were follow-up or the patients that were treated with the radioiodine. 95.1% of the patients in the follow-up group had no event at 3 years. And in the radioiodine group, there were 95.9% of the patients So the numbers were not different. There were no inferiority of the follow-up when compared to the radioiodine ablation group, and the number of the subsequent surgery or radioiodine administration was very low, was about 2% in both groups. Unfortunately, we do not have such strong data, such high quality data in the intermediate group of the patients, so we have to rely on other sources. For example, the best sources what we have are the retrospective data of retrospective analysis of the big sets of the data. But unfortunately, with the retrospective data, we have a rather contradictory result of this analysis. And here we have one of the study, more than 20,000 of DTC patients from the SEER database that were treated between 2004 and 2014. About 70% of the patients were treated radioiodine. About 2/3 of the patients had lymph node metastasis or extrathyroid extension. And as we can see, they are the prognostic factors that we all know, and male gender or older age or bigger the tumor or lymph node metastasis were associated with the lower disease-specific and overall survival of this patient. But when we looked at the treatment and on the radioiodine therapy, we can also see that there was influence in this group of patients on the risk of the death, and the radioiodine reduced the risk of the death in this group of the patient. And very similar analysis was done by another group, but from a bit different perspective, because this group looked not only on the risk factors, but they also looked how it's changed in the different age group. And what they show is, yes, there is a decreased risk of death in the intermediate risk group of the DTC, but in the younger patient, less than 45 years of age, this benefit is the lowest. And also some prognostic factors, like, for example, in small tumors or in lymph node, in positive margins, there is not influence on the disease-free survival at all. So it seems that age, like we know, is of importance. But as I said, the data are contradictory. There are some other studies, like, for example, from the Memorial Sloan Kettering Cancer Center with more than 1,000 patients and about 45 of them with the intermediate category, and more than 400 that have tumors PT3, PT4, and they show no benefit of radioiodine treatment with respect to the local recurrence-free survival, regional recurrence-free survival, on distant recurrence-free survival. And we can ask ourselves why they are so contradictory results. Of course, we know that retrospective data can be biased, and then can be selection bias. For example, we select different patient groups for the study, not exactly the same, not exactly the same treatment. For example, there can be differences in activity of the radioiodine or time of this treatment after surgery. Then can be some information basis, like, for example, changes in the diagnostic tools. Like I said, we cannot compare our landscape of thyroid cancer nowadays with what was done by Mazaferi and Young. And they can be also confusion bias from the different relationships or variables that are not taken into account in this analysis, like, for example, let's say molecular profile. So again, I would like to say that prospective randomized study would be, of course, the best to assess whether this treatment should be applied to the differentiated thyroid cancer or not. But although we do not have such data, we should do our best and try to select patients who benefit the most from the radioiodine treatment, and to select patients that maybe can omit this treatment. And so the most important, I think, is the thyroglobulin and neck ultrasound done after the operation to be sure that we have the patient group that is not with persistent disease. And then we can look for some prognostic factors that can be applied to select the patient who can benefit the most. And as we know, age is a very important prognostic factor that is included in most staging and prognostic scale. It is also included in the AGCC staging system, although it was changed the cutoff level from 45 previously to 55 nowadays. But we should remember that with respect to age, there is no breaking point. So I mean, whichever age will be set, there will be always better prognosis in the younger patient than the worse prognosis in the older patient. And now we can see in a quite large set of patients, more than 15,000 patients, that irrespective of the stage of the disease, whether it was localized, regional, or remote patient, the oldest patient had the worst prognosis. And the number of the observed cancer-specific deaths or persistent disease at last follow-up in patient here, it was more than 60 years of age, was always exceeds the expected number, and it was highly significant. And also, it was an analysis that to establish whether administration of the radioiodine is protective both for disease-specific survival and disease-free survival in those older population of the DTC patient. And yes, both the survival and the disease-free survival were better if radioiodine was administered by the factor of about 30 to 50%. And there was also other analysis that also looked at the radioiodine treatment in this older patient, and it showed that in patients that are more than 35 years of age with primary microscopic extrathyroid extension or lymph node metastasis, dual radioiodine is related to a better prognosis. And now to address minimal extrathyroid extension, like was mentioned by Agnieszka already, it is also an intermediate group of in the risk. But first of all, sometimes it is very difficult to assess. Sometimes they can be scars after the thyroid biopsy, and it's difficult to say whether the thyroid capsule is disrupted by the biopsy or by the tumor. And here we have a meta-analysis of 8 studies, more than 20,000 of patients, to assess whether this extrathyroid extension is related to a worse prognosis. And yes, there is a statistically significant difference, but we should not only look at P, that is significant, but we should also look at the numbers. And from the clinical point of view, I think that 6.2 and 7%, they do not any difference with respect to the risk of recurrence. And here I would also like to show a prospective observational study, almost 200 patients with tumors less than 4 centimeters and with minimal extrathyroid extension without any other adverse factors, and the patient were not treated with radioiodine, and the risk of the structural recurrence in this group of patients was about 2%. So omission of the radioiodine treatment was not related to a bad prognosis, and the median time of observation in this group of the patient was more than 6 years. And here we come to the lymph node metastasis. And we know that lymph node metastases are no 0-1 result, not yes or no, but we know that worse outcome is related to the big lymph nodes with the extranodal extension that is more related to both to the regional recurrence, but also with distant metastases. But what we can do with the patient with intermediate risk of the recurrence, when there are not those big lymph node metastases. Here is one approach. It's, for example, to count the lymph node density, so the ratio between number of the positive lymph nodes and the total number of the excited lymph nodes. And here is the work from Japan, I think. And the disease-specific survival was better in those patients where this density was lower than 0.3. And here is also the American study based on the big databases that show that if we have less than 6 lymph node excites, the risk of the recurrence is higher. And it is now also from the other field of the oncology, for example, from the head and neck cancer, that we have to remove at least 10 lymph nodes to be sure that the patient is correctly staged. And this is maybe not directly related to the selection of the patient that should be treated or not be treated with radioiodine, but we should always bear in our mind the adverse effect of this treatment. And generally, the treatment is very well tolerated by the patient. There can be some radiation-related salinitis, but it's not a big problem for the patient. But what should we bear in mind is the recent secondary cancer. The risk is minute and it's not big, and really we have to assess it in a very large group of patients. There is one additional cancer for hundreds or even thousands of the patients, but there is. And of course, when we do it on the database, sometimes we do not know what exactly was the radioiodine activity was given. But nowadays there are more and more data that also shown that maybe the problem is in the radioiodine activity, and the smaller activity are more safe than the larger one. Here is the cutoff at the 200 millicurie, but they also work that the cutoff is on 300 millicuries. So maybe the one treatment, especially if we do the lower activities, 30 to 100 millicuries, are safe. But if you want to repeat the treatment in the patient that have not persistent disease, we should always think twice before we do it. And I would like to finish this presentation with the ETA 2022 consensus statement, or the indication for post-surgical radioiodine therapy in differentiated thyroid cancer. And in the intermediate risk category, right, therapy may be indicated and should be tailored according to the individual cases, and should be more often considered for the elderly patient. And if we have especially younger patients with minimal extracorporeal invasion in the microscopic or few lymph node metastases, right therapy should be decided mostly on what we have after post-surgical evaluation of the patient with thyroglobulin and neck ultrasound. And at the end, I would like to stress that the best decision on the patient management are always done with multidisciplinary tumor board, because in that case we have a broader landscape of our abilities and patient care. Thank you very much for your attention.
Thank you very much, Daria, for the very important lecture. And now your lecture is open for questions. Jolanta, are there any questions?
So far, we do not have any question to Daria, so maybe let me start. Daria, I have a question regarding postoperative disease staging. Is in your opinion, postoperative radioiodine treatment necessary in patient with intermediate risk DTC who shows an excellent an excellent treatment response after surgery?
First of all, the excellent treatment response should be defined in the patient that have still some remnant tissues, and the thyroglobulin more than 1 nanogram in the suppression is very common. And second question is that we do not have really the data that show that the omitment, especially in the elderly patient, gives the same result as in the patients that were not treated. We have done, as you know, our own prospective observational study, and for the study there were only qualified patients with a good response, but the thyroglobulin level could be up to 10 nanograms under stimulation. And honestly say, with a rather short time of follow-up, we did see only I think 2% of the structural recurrence, and we did not see much upstage in post-therapy whole body scan. So it is an important question, but I think it's still open.
Oh, thank you so much. I check. Oh yes, I have one question to you, Daria. The question is, would you recommend radioiodine as PTC postoperative therapy in children? What are the pros and cons of RAI in children?
If you asked me this question, let's say 10 or 50 years ago, I would say yes, we should go with the radioiodine. But I should stress again that our diagnostic tools changed substantially during the years. And nowadays, first of all, we can better stage the children, and second, they are better operated, as Agnieszka already said. So I wouldn't be afraid to give the radioiodine if the stage of the disease is high, if there are multiply lymph node metastases, if there is extra thyroid or extra lymph node extension, if there are lymph node metastases. But bearing in mind that there are young patients with a high risk or higher than older patient risk of the radiation-induced secondary cancers, I would go first with the whole body scan and the stimulated thyroglobulin, and only if I have any suspicious for the persistent disease, I would go with the radioiodine.
Thank you very much. I will check whether you have another question. If not, thank you so much for an excellent lecture. And I think we may move forward the last presentation. These are just closing remarks. I would like to ask Barbara Jajab for the lecture.
It is my pleasure to present the concluding remarks of our interesting webinar. Please allow me to recall the titles of the. It's clear to us that the management of non-metastatic thyroid microcarcinoma, it is clear to us that the management of non-metastatic thyroid carcinoma is a task for endocrinologists. As Yolanda stressed, thyroid carcinoma, which does not exhibit lymph node or distant metastasis, is a rare disease, contrary to papillary microcarcinoma, which tends to become a frequent disease. However, we are aware that non-metastatic thyroid carcinoma is a heterogeneous disease, and we endocrinologists are obliged to analyze the probability of finding post-operatively low-risk thyroid cancer, which deserve lobectomy. We can base our prediction on the analysis of fine needle aspiration biopsy. FNAB allows for the diagnosis of papillary thyroid carcinoma, and we know that this histotype is more often low-risk thyroid cancer, provided, of course, that we do not see suspected neck lymph node metastasis by neck sonography. Obviously, thyroid cytology has its limits. It does not allow us to differentiate PTC variants reliably, particularly those related to poor prognosis and whose post-operative histopathological diagnosis forces us to deal with high-risk thyroid cancer, like tall cell variant, hobnail variant, or columnar cell variant. Also, as we all know, thyroid cytology does not differentiate between follicular carcinoma and follicular adenoma. It is also evident that we cannot base only on the nodule diameter. Even if it is smaller than 2 centimeters, and shows no lymph node metastasis, it is always possible that the surgeon planning the thyroid lobectomy will find macroscopic neck lymph node metastasis intraoperatively. In particular, it concerns the central neck compartment, where nodal metastases are difficult to find in neck sonography. In such a situation, the surgeon will be prompted to change the operation plan and perform total thyroidectomy instead of lobectomy, and with lymph node dissection in facing of high-risk PTC. That is why we insist that a malignant thyroid nodule should be operated on by an experienced thyroid surgeon who performs at least 50 surgeries per year. Such a center is supported certainly by a multidisciplinary team, which involves an experienced thyroid pathologist who knows how to differentiate thyroid cancers from borderline tumors. And Eva showed us how challenging task it is. The diagnosis of borderline thyroid tumors like NIFTP or WDT is a challenge to the endocrinologist concentrated around Endo-ERN. These tumors are rare, were introduced by WHO, as Eva told us, in 2017. And up to now, we have no recommendation how to follow up these patients. Obviously, prospective studies are necessary to provide evidence-based knowledge. And I'm convinced that this is the task of Endo-ERN. Coming back to the question, how to predict low-risk thyroid cancer, we are aware that we won't cooperate with nuclear medicine specialists. A careful decision about the individual indications for post-operative radioiodine administration is necessary. And I see here the important role of MDT. And molecular risk factors, it's difficult to admit, but still they are not sufficiently reliable, I believe. And more prospective studies are required. As Dagmara extensively discussed, we realize that molecular examination are still insufficiently reliable to foresee low-risk thyroid cancer and adequately plan thyroid lobectomy. And prospective studies are required to provide sufficient evidence. We could discuss a long